Go ahead and move on to our second speaker in the panel. Dr. Ryan Vandrey is Associate Professor of Psychiatry and Behavioral Sciences at Johns Hopkins University and studies psychopharmacology of cannabis in human trials. And his talk is entitled Controlled Laboratory Studies Evaluating Cannabis Effects.
Thank you. So I'll start with the disclosures. I have been a paid consultant or received honoraria from several companies or businesses that work in cannabis. And by way of background, I just want to kind of highlight one of the major issues that we face as researchers is that when you talk about cannabis or medical marijuana, it's not entirely sure what you mean. And so what we have on this slide here is just a representation of the hundreds of different products that are out there right now. We have everything from raw plant material to oils to concentrated products, transdermal gel pens, tinctures, gummy bears, and even dog treats. And so in addition to that, we have pharmaceutical cannabinoids, and people often forget that those exist, so I want to point that out there as well. And there's controversy regarding the distinction or the difference between these products. There's different chemical makeup. We've heard people talk about cannabidiol versus THC. But there's hundreds of other products in the cannabis plant, and we're not entirely sure what any of those do and how they contribute to either the therapeutic potential or the harmful consequences of the plant. And so I think we need a lot more research to help tease this apart. And as part of this forum and the call for additional research as part of this report, I want to encourage anybody out there who's thinking about getting into cannabis research to do so. So the perspective that we're coming at here is that there are a lot of research needs. This is just a very brief rundown of what some of them are, but some of the things that are relevant to the research that I'm going to talk about today. Are there differences in the time course, type, and severity of effects based on the dose and the route of administration? So on that previous slide, you noticed that there were things that people would swallow, people would inhale, and you would inhale via smoking or vaporization, things that were suppositories. There were transdermal products. And so drugs have different pharmacokinetics and different time courses based on route of administration, generally speaking. But we don't know a lot about what the differences are for cannabis or cannabis products. Are the route differences in bioavailability or biomarkers of exposure? And so there's been a little bit of data on that, but not a lot. How big is the impact of tolerance? So we know that people develop tolerance to the effects of cannabis, some of them more so than others, and a lot of the therapeutic evaluations of cannabis for medical purposes to date have been a relatively short duration. Population differences. So we need to understand whether there are genetic differences in the response, sex differences, differences based on ethnicity or other variables, age. The contributing effects of the various chemical constituencies in the plant I mentioned before. The question of the impact of the non-user. So secondhand smoke has become an issue, and we did a research study to try to address that. And all of this kind of comes down and boils down to is if you're a physician, what do you say to your patient? They come, and people get this all the time. The physicians that I work with get the question all the time. I'm not a physician. I get the question all the time. I've got pain. What should I use? How should I use it? And so we need data to help address these questions. And to date, most of what we know about this stuff is based on studying the acute and chronic effects of smoked cannabis in current non-medical users. Okay, so very restricted within what we're talking about now, that's a global expanded kind of cannabis area. Both now the transition to therapeutic use of cannabis, introducing cannabis to novice, naive users in the therapeutic context, and looking at what those long-term effects are. And so I'm going to describe a series of studies that I've been conducting up at Johns Hopkins that have been funded by the SAMHSA Division of Workplace Programs. Now, their primary interest in coming at this is to inform federal workplace drug testing programs, so really focusing in on the pharmacokinetics of acute dosing of cannabis through different routes of administration. But my interest is a little bit beyond that and looking at some of the pharmacodynamic effects. So what are the acute effects? Does it impair cognition? What's the experience of the user? And so we've got a nice partnership here in trying to address both of those questions. So we enrolled non-tolerant healthy adults in these studies. These are not treatment seekers, they're not current cannabis users, and they're not seeking medical benefit. We varied the route of administration and the dose across studies, and we looked at basically the same measures across studies. And just to kind of describe what we did here, we have cannabis administered through 3 routes of administration in a controlled laboratory setting. We obtained our cannabis from the National Institute on Drug Abuse. And we've done studies now where we have passively exposed individuals to secondhand smoke. We've vaporized cannabis, had them eat a cannabis-containing brownie, and smoke cannabis through a pipe. Before and after each drug administration, we collect a number of assessments. We collect biological samples, including blood, saliva, and urine. We collect cardiovascular effects, blood pressure and heart rate. We collect subjective drug effect ratings, where we ask people, do you feel a drug effect? Is it a good effect? Is it a bad effect? Do you feel anxious, nervous, sedated? Those kinds of things. And then we have a brief battery of cognitive performance tasks that measure things like psychomotor performance, working memory, and divided attention. And so what I'm going to do now is kind of give you a little bit of a summary of how the effects of cannabis have differed within our laboratory study based on route of administration. And this is data collected over 2 different studies. In each study, we enrolled 17 healthy adults. In the smoke and vaporization comparisons, it was the same individuals for all doses across both routes of administration. The oral administration study was a separate study, but 8 of the 17 people in that study also participated in the smoked and vaporization study. So we have a full crossover across routes of administration for 8 individuals. We had an even split with regards to sex, and each participant in each study received each dose, so it's a within subjects design. Participants had not used cannabis for at least a month, in some cases several years. They were fed a standard low-fat breakfast at the beginning of the day, and we conducted assessments at baselines and for 8 hours after administration. And so while we went up to the 50 milligram dose in the oral administration study, the data from the 50 milligram dose were not very different from the 25 milligram dose. We didn't go up to 50 milligrams because of that in the oral and vaporization study, so I'm only going to show data from the 10 and 25 milligram THC doses. And what you can see in this slide here is that we see dose-dependent effects in terms of increases in subjective ratings of drug effects from 10 to 25 milligrams. And we see differences based on route of administration. With the 2 inhalation methods indicated here with the blue and the purple lines, we see stronger drug effects following vaporization compared with smoking. And we see an immediate increase after administration followed by a slow decline over time. When oral administration was used, we see a much slower time course, slower time to onset, and a longer level at peak effects. Interestingly enough, the overall magnitude of drug effect between the smoked and oral routes of administration were comparable, even though the peak effect occurred at different times. And the vaporization was higher than both of those. So the vaporization seems to be a more efficient route of delivery. This shows the cardiovascular response across routes of administration. So cannabis very reliably increases heart rate. And you can see, again, a comparable pattern to what we saw with the subjective ratings of drug effect. The time course is a little bit shorter on the cardiovascular effects. It doesn't last as long. But again, the magnitude of effect was comparable between oral and smoked. Vaporization produced a higher drug effect. And the time course was, we had immediate effects with inhalation and more drawn-out effects with oral administration. And then when we look at cognitive performance, so this is data from a working memory task where participants are asked to add single integer numbers repeatedly. They have to add the number that they're looking at plus the one that they previously saw and indicate the answer on a computer screen. And here we're seeing a nice dose effect difference that I think is important to point out when we're thinking about the broader spectrum of use of cannabinoids in therapeutic purposes and even non-therapeutic purposes, is identifying doses in which we have impairment in individuals. So 10 milligram THC dose did not produce impairment on this task, but 25 milligrams did across routes of administration. And you see the same thing here on a task of psychomotor ability. So in this task, a digit symbol substitution task, individuals had to type patterns that they saw on the computer screen using a keyboard. You can see that we saw impairment on this task at the 10 milligram dose with vaporization, but not with smoked or oral routes of administration. But at the 25 milligram dose, we saw impairment across all 3 routes of administration. Again, just to highlight that there's differences in the time course of impairment here, so that's going to be something that has to be factored into education to individuals about using cannabis. And the blood levels that we observed in this study correspond to what we see pharmacodynamically, in that we see greater blood levels of THC following vaporization compared to smoking and oral administration. Note here that in this case, when we're looking at pharmacokinetics, we see a much bigger disconnect or disproportionate levels between the oral and the inhaled routes of administration. So oral cannabis didn't produce blood THC levels near to the extent that it did following smoking. And so that suggests to us that looking at blood levels is not necessarily the best way of determining bioavailability. So just because it's not systemically available doesn't mean that it's not in tissue and having an effect. And so with route of administration, looking at blood levels and pharmacokinetics becomes important. So just to kind of expand on what other outcomes we saw, we basically saw that same pattern of results for many other subjective drug effect ratings and cognitive performance effects that we measured. We found that cannabis increased ratings of feeling tired and sleepy, feeling subjectively that your heart was pounding or racing in your chest, feeling nervous and anxious, feeling hungry or having the munchies, feeling paranoid, feeling irritable, feeling sick, feeling restless, and decreased ratings of feeling alert. We found in the oral administration study that females tended to have stronger effects than males. But consequently, and I didn't get this in my slides before coming down here, we just did an analysis of sex differences in the smoked and vaporization study and found fewer differences. And when we did find differences, we actually found stronger effects in males versus females. So I think it's important to continue to try to evaluate and understand sex differences in this research, and route of administration, metabolism, some things like that may play into what we see and how they're different. Adverse events, I think, are important to talk about. So some of that was reflected in the prior slide where we talked about some potentially negative consequences or negative feelings following the drug administration. I wanted to mention the kind of more moderate to severe types of events that happen. None of these would be considered severe adverse events, but we did have 6 instances where individuals vomited after an acute dose of the drug. In the oral study, that happened for 1 person after the 25 milligram dose and 3 people after the 50 milligram dose. It happened following 1 person smoking 25 milligrams and 1 person vaporizing, I believe, 10 milligrams. There were 3 instances of moderate to severe panic or anxiety reactions in 2 cases following oral administration and 1 following vaporization. Those symptoms lasted for 45 minutes to an hour. They were resolved on the unit. The people were not comfortable in any way, but they also didn't pose, it wasn't a medical risk. But they had a very unpleasant time. In one of those cases, the person also reported experiencing hallucinations and a kind of dissociative or out-of-body experience, similar to what would be expected from a drug like ketamine. And nausea, dizziness, and somnolence were observed pretty much across the board at higher doses. So in summary of these studies, we found orderly dose effects across most of the pharmacodynamic measures that we assessed. The 25 milligrams and higher THC doses consistently were different from placebo in both subjective intoxication and cognitive impairment. That was evident and needs to be factored into dose considerations for commercial products. Vaporization was, again, more efficient in terms of a route of delivery. The time course was different between inhaled versus oral, and differences based on sex were observed. Now, the third study I want to talk about was secondhand exposure study. In this study, we conducted an experiment looking at secondhand smoke exposure under 3 different conditions. One was with a 5.3% THC cannabis being smoked and no room ventilation. One was with 11% THC cannabis being smoked and no room ventilation. And then we repeated that with the ventilation turned on. In this experiment, we put 12 individuals into a room. We gave 6 of them 10 joints and told them that they had 1 hour to smoke as much as they could. They were thankful for that. And here I'm illustrating the difference or the effect of the ventilation on the room environment and the level of smoke. So when we had the room sealed up, the smoke was so dense that people had to put swim goggles on to keep their eyes from burning. And that level of difference translated to the data that we obtained. So on the left-hand panel here, we show the self-reported ratings of drug effect and blood THC levels in the people who were actually smoking the cannabis. And then in the right-hand panel, you're seeing feelings of drug effects and blood THC levels in the non-smokers. The squares are individuals when the room was sealed, and the triangles are when the ventilation was turned on. And what we observed was that the non-smokers did report a contact high in this unventilated environment. It was less of a drug effect than the people directly inhaling the cannabis as we would expect, but it was significantly different in terms of subjective drug ratings compared with placebo, and also resulted in mild impairment on some of the cognitive performance tasks that we did. And there was a little bit of an increase in terms of we were able to document biological exposure in the non-smokers through both blood, urine, and saliva tests. So to summarize that, we did find that room ventilation has a significant impact on secondhand smoke exposure. We didn't see a difference with the potency of the cannabis being used in this study, but that was there were issues with the design there where the cannabis smokers smoked more of the high potency cannabis than they did the low potency cannabis. So I can't quite explain that. But I think the highlight is that under extreme circumstances, such as an unventilated small room and an extended period of exposure, individuals can experience some effects of cannabis. Positive drug tests can occur within the first couple days after exposure. Most likely not far beyond 24 hours, though. And the likelihood of that positive test will depend on whether you're testing urine, blood, or saliva, what cutoff you used, and the time since exposure. Now, I want to acknowledge several limitations of the research I've just described. One is that reliable measures of dose and product use is very difficult in observational research, so we had very controlled dosing in these studies. Trying to extrapolate this from how to use a product purchased from a dispensary is near impossible. There are regulatory limitations for research with state legal products, so this is really only us evaluating a product that we obtained from NIDA that is high in THC and low in CBD. We used the same batch of plant material for all 4 studies. And we also only evaluated these effects in people who are not currently cannabis users or very infrequent users. So the impact of tolerance on response and the time course is going to be an important thing to consider. With the passive exposure study, we only looked at one possible scenario in that people were in an environment for 1 hour. We don't know what that would look like if they're in the environment for a shorter period of time, for a longer period of time, with more smoke, a bigger area, more importantly, we don't know what it would be like with individuals who are exposed repeatedly to secondhand smoke. So I think the take-home message is here that there are a wide variety of products being used by individuals, and we need a better scientific understanding of what the impact of product formulation, chemical constituency, and dosing for route of administration has. We need to understand both this in terms of the therapeutic beneficial effects as well as harmful consequences, and use that to make clinical decisions and regulatory decisions. I think secondhand smoke exposure is a concern that needs to be addressed, and we need science to inform regulatory considerations in this area. Our future desires are to replicate what we've done with high CBD, low THC cannabis, and as well as pure compounds. We want to look at evaluating the merit of the whole plant versus single molecules, and to evaluate very specifically what other effects or what other constituents of the plant contribute to the effects of cannabis. There are other routes of administration that we haven't touched, transdermal, suppositories, and it seems like every other week a new way of administering cannabis comes out. We want to evaluate plant material versus concentrates or oils. We don't know what that extraction process does to the material that we're getting. And evaluating additional biomarkers that might, or behavioral tests that might be sensitive to differentiating acute intoxication or impairment versus residual cannabinoids or characteristics of the individual. And I think what we would really like to see in a huge area of benefit for scientists here would be development of controlled dose delivery devices. With that, I want to thank my collaborators, NIDA for supplying the drug, and SAMHSA and RTI for funding all of this research. So, thank you.
All right. So I can start off again while we get some. What's that? We have some questions. Oh, okay. Go ahead.
Yeah, so Ryan, very nice presentation. I really enjoyed that. So I don't know if I've ever seen another study on the oral came from the brownie, correct? The oral dose?
Yep.
So yeah, it's very impressive. I'm not sure I've seen that in the U.S. before, so that's nice work. Quick question though, 25 milligrams, if you were to, in Colorado, if you were to buy an edible, usually 5 milligrams, 10 milligrams is kind of the max somebody would do unless they had a lot of experience. 25 would be way high. I'm just kind of curious what your thoughts are about that.
Yeah, so we selected the dose range here based on two things. The lower end, the 10 milligram dose, was based on the unit dose regulation in the state of Colorado. And the high dose of 50 was based on a product sampling study we did in California and Washington, where the median dose of edible products that we purchased from dispensaries was 54 milligrams. And so even though Colorado restricts their edible THC content to 10 milligrams, I believe that's only for the non-medical dispensaries. I don't know if you still have separate medical dispensaries, but we saw products that contained far higher doses of THC than that, including one in California that had over 1,200 milligrams of THC in it. So where we kind of set it up to be on the lower end of what we saw in dispensaries because we had non-tolerant individuals in our studies, but we wanted to kind of get a good sense of representative dosing.
Yeah, that really illustrates sort of what we don't know, right? I mean, there's hugely varying doses, and if you talk to people with considerable experience, they'll take much higher doses. But for naive people, even 10 can be a really high, pretty high dose. that's why I was just kind of curious. But again, I think it illustrates all the things that we don't know and why we need to do this work.
Yeah, sure. And we saw individual variability in response, as expected. Not every drug affects different people the same way. But 10 milligram dose, we actually found overall averaged across our 17 individuals in one study and 18 individuals in another, or actually 6 of the 18 in the other study. 10 milligrams didn't produce impairment on cognitive performance or produce much, if any, unpleasant drug effects. It actually was kind of a good dose for them. It was when we jumped to 25 and 50 that bad things started happening.
Thank you. It was very interesting and very important work with health and public health ramifications. Wondering if you were thinking about doing the same sort of thing. You did this for people who hadn't used cannabis for at least a month. For example, the cardiovascular effects are said to, people are said to accommodate to them after a few weeks, but wondering if you've thought about doing this for the same kind of reasons in people who are using currently.
Well, luckily, I don't have to do that study because Marilyn Hustis did.
Oh.
The same time I was doing these studies, Marilyn Hustis, formerly at NIDA IRP, conducted a comparable study where she evaluated oral, smoked, and vaporization in infrequent and frequent current cannabis users.
I'll look it up.
The data for that are just being published now.
Oh.
A couple papers are out. And
Okay,
knowing her,
great.
I'm sure there's a few more coming.
Thank you.
Yes, first of all, thanks very much for a really interesting panel. I have a question. My name is Jeff Zinsmeister. I'm with Smart Approaches to Marijuana. The question is about the secondhand exposure element. In the context of the social use initiatives that one of which was passed in Denver just this past year and are being considered elsewhere, which basically allow restaurants and cafes to permit marijuana smoking sections in the on premises, were the secondhand smoke tests that were being done obviously they're under controlled conditions, but were those conditions designed to attempt to reflect that type of environment? I'm just thinking back to my earlier days when they allowed, younger days when you could smoke cigarettes in restaurants, et cetera.
Yeah, so what we did there is we engineered the chamber that we had people sit in on there to reflect current building code for HVAC systems. And so the ventilated and unventilated conditions of that study are built to reflect and translate to, in one case, somebody sitting in a room 7 feet by 10 feet and the air conditioner's turned on. And in the more extreme case, people sitting in, say, a college dorm room that's 7 feet by 10 feet, and they've got the windows closed, the vents closed, and a towel stuffed under the door. And so again, what we saw in that study is two very different air environments, and that was illustrated in the pictures. So with the ventilation system turned on, we did not have drug effects reported by the individuals, and we saw very low, if any, biomarkers of cannabinoid exposure.
Okay, great. Thank you.
Hi, Bob Wallace from the committee. Let me add my thanks to your work as well. One of your early slides went by pretty quickly on some of the general issues. One particularly I think you mentioned was workplace, and I wondered whether you are doing any work in the workplace.
Yeah, so the data from this is being used to inform SAMHSA's federal mandatory guidelines on workplace drug testing. So all of the data coming out of this is going to SAMHSA, and they're using that to refine the federal workplace drug testing procedures, and that includes, determining what cutoffs for tests to be used, how to interpret outcomes, and things of that nature.
Do you do motor tests and things like that? Mechanical tests?
We have that battery of cognitive performance tasks that we do, so we're able to correlate or to evaluate the relevant biomarkers with performance on measures of psychomotor performance, attention, and working memory. And what we've found is that they don't correlate very well at all. And so to date, we do not have a reliable biomarker that can predict whether somebody's impaired due to cannabis or not. And we're stuck or left with instances where you need to determine impairment through other routes or other methods because there's an inability to differentially identify someone who's currently intoxicated versus someone who used cannabis 2 nights ago. And the route of administration, if you notice, if you're looking, depending on the biological matrix you're looking at, can have a profound impact on that. So with inhalation, shortly after somebody smokes cannabis, we see high levels of blood THC that we could feel pretty confident, say, yep, that person just used cannabis. But at the same dose and the same level of impairment, somebody who ate a cannabis brownie would not exceed that level.
Ziv, if I can sneak in one more question. Just quickly, when you saw heart racing and acute effects, do you see arrhythmias at all?
We didn't measure that here, so we didn't have people hooked up to a sensitive enough material to look for that.
Really wonderful set of data that really speak to the emerging trends of cannabis use, including increased potency and different routes of administration. So I'm wondering, something that's been coming up with regards to increased availability of cannabis and these different trends of use is that recently in an epidemiological report, we've seen that there's been increased use across the country as well as increased incidence of cannabis use disorder. And so I'm wondering if you looked at subjective effects that might be indicative of abuse liability in this group, and if they differed across doses and across routes of administration, or maybe if you've decided to probe self-administration as an endpoint?
Yeah, so we have not allowed them to self-administer things, anything beyond the single acute dose that we asked them to do at the beginning of each study. After going up and visiting with Meg a couple weeks ago, she called me out on not including a visual analog scale of liking or take again. So we don't have some of those more traditional abuse liability type assessments. We kind of got something similar to that in that we asked whether the drug effect was good or unpleasant. At the lower doses, we found an increase in ratings of good or pleasant drug effects. And at higher doses, we had both increased ratings of good and unpleasant drug effects. And that kind of translates to what I talked about with the side effects. So you have an increased incidence of unpleasant effects at higher doses, but that doesn't mean that they wouldn't have abuse potential.
And one other question with regard to the sex differences that you briefly mentioned. I'm just wondering if some of the adverse effects that you saw, that, you know, the anxiety, the hallucinations, were those seen mostly in men or women? Or do you have an idea of that?
Off the top of my head, I couldn't tell you. I mean, in the oral administration study, across the board, it was only a subset of our outcomes, but we did see an increase, higher magnitude of drug effects in females versus males. We saw far fewer sex differences with the inhalation study. But again, it's difficult for me to talk about whether there was any cluster or constellation of symptoms that kind of predicted a certain type of response, because the smoke and vaporization data is really we just finished the study last month. So we're still looking at the data there.
Great, thank you so much.
Thanks.
Hi, from the webcast, I have 2 clarification questions and then 1 follow-up question. Did you observe the results of CBD in the bloodstream the same way you observed THC? And relatedly, what were the units that you looked at? Was it picograms or nanograms per mil in the blood?
Okay, so in this study, we used cannabis that was very low in CBD content. I think it was 0.3% CBD. And our focus was on, because there wasn't much there, we weren't too interested in it, and CBD is not used for workplace drug testing, so we didn't measure it. With regards to the blood data that I showed, those data were in nanograms per milliliter of blood. The saliva specimens that we test, there's assays that are sensitive to the picogram per milliliter of blood.
Another follow-up question, do you foresee roadside performance tests for cannabis-intoxicated drivers?
I think that there's a lot of interest in developing that, both from the public health and law enforcement perspective. Research that has been done in my lab and in other labs, Maryland Eustis in particular, has demonstrated that cannabis can impair driving performance. And, you know, there's a desire to be able to determine whether somebody on the roadside is intoxicated and impaired as a result of cannabis use. But what people tend to forget or not really understand is that alcohol is the outlier and that we have one of those tests for that. We don't have reliable tests for impairment of other drugs of abuse, or even medications that can impair driving.
And one last question from the web, and then the rest we'll take at the larger Q&A at the end of the session. Do you have any data on differences of cannabis effects on youth versus adults?
No, I don't. We tend not to study kids in our laboratory.
Okay, great. Thank you.